And good evening. Thank you so much for watching HealthLine on PBS Fort Wayne. I'm Mark Evans, your host, along with our special guest tonight, Dr. Jeremy Wilson. And he is a general surgeon. And tonight's topic, since it is Colorectal Cancer Awareness Month, we're talking about colorectal cancer, and we'll talk about some other cancers of the colon as well as we go along. Just want to let you know, it is a live show, of course, and we always take phone calls, but tonight will be a little bit different. We have some technical difficulties. We tried so hard to fix before the show started, but weren't able to do that. So those will be fixed, I'm sure, tomorrow morning. So we do have a few questions in the can, so to speak, from people who have actually known about the topic we'll talk about tonight and emailed those and gave us word of mouth. So we'll go ahead and address those tonight as well. But in the meantime, Dr. Wilson, thank you so much for joining us.
Well, thanks for having me.
You were here 3 months ago or something like that, a very interesting conversation.
Thank you.
And we are going to talk specifically about colon cancer tonight. And because you've had a lot of experience with that.
I have.
You as a general surgeon, and these days they pretty much have colorectal surgeons pretty much targeted for that particular entity. Is that correct?
It depends on your geography, really. If you're close to a city, then yeah, most of the time you're going to have a colorectal surgeon available to you. For certain types of cancer operations, especially rectal cancers, you definitely want to have someone that has a lot of experience, such as a colorectal surgeon. Okay. If you're more out in a rural area, you may get a general surgeon, but don't worry, general surgeons do have that same knowledge, have done a lot of the same types of operations.
Right. Well, good. We're in good hands tonight, and we thank you for being here. Let's go ahead and start with some basic colon cancer stats, some statistics, if you don't mind.
Colon cancer right now, at least in America, is the number 3 most common cancer for both men and women. It's the number 2 cause of cancer deaths in men and women, expected to be well over 100,000 cases diagnosed this year of colon cancer and close to 50,000 of rectal cancer. So.
Oh, wow. Yeah, and I just, before the show started, I was able to get some statistics from the American Cancer Society, who, of course, is sponsoring Colorectal Cancer Month.
Right.
They are predicting that the number of colorectal cancers in the United States, and this might be fresh news to you, and it's fairly, I haven't seen this come up yet until today, but about 105, well, I'm going to round it out to 107,000 new cases of colon cancer. Oh. 54,000 of those in men, 52,000 or close to 53,000 in women, and about 46,000 new cases of rectal cancer in men. The 27,000 range and the 18,000 range for women.
Wow.
So that's quite a bit. I mean, we're talking about millions of people, of course, in the United States, but that's a very high number, and that doesn't even talk about the number of deaths that can occur from those cancers.
Correct. Yeah.
So we're going to talk about prevention. We're going to talk about treatment. They've come a long, long way, as you can attest,
yes.
Especially in the last decade or so, on how to treat colon cancer, as well as help people survive many, many years after they have conquered it. So that's out of the way. And now there are 6, basically, from what I can count, and you're the doctor, you're the physician, so you correct me if I'm wrong, but there are about 6 different types of colorectal cancers. To my knowledge, from what I can count today.
The main one that people focus on when we're talking about colon cancer in general is what are called an adenocarcinoma. That's the one that most people will equate with colon cancer. There are other cancers that can affect the colon as well. They can also affect other parts in the body, though, such as a gastrointestinal stromal tumor, which can occur, stomach on down, carcinoid tumors. I've identified actually several of those in my career during colonoscopy, but they can occur anywhere else. They can occur in the upper GI tract. They can occur in the lungs. Lymphoma can occur anywhere, but I've seen a few cases of colon involvement with lymphoma.
We've always got our prayers and our thoughts in for a mayor of our city, Mayor Tom Henry. Recently diagnosed with, well, I don't know if it's been recent, but he made a public announcement a couple of weeks ago about him having stomach cancer. So that isn't necessarily caused by the colorectal cancer. That's an entity of its own. Is that right?
For the most part, yes. There are different types of stomach cancer as well. There's one that is associated with the H. pylori infection. Some of the other ones, there are some polyps that can develop in the stomach and can progress to a cancer, very, very similar to what a colon cancer does. So it just depends on the type.
But the one we are talking about tonight in particular is the one that starts with polyps. Is that correct?
That is the main one. The majority of colon cancers are what are called adenocarcinomas, and those are the ones that we believe start as polyps. And the idea with the screening programs is to identify it and remove it at that polyp stage, and therefore it never gets a chance to turn to cancer.
Okay.
I've read that if you're current on your colonoscopies, it's going to decrease your chance of getting colon cancer by about 69%. Your chance of dying from colorectal cancer about 68%.
And we talked about something in the green room where we met before the show started. You mentioned 1990, people born in 1990, and I found that, I wrote that down here. I said, well, a little question mark. I'm going to ask about that on the show. So, people born in 1990.
We were talking about when should the average risk person start with colon cancer screening, and previously it had been 50 because we saw most of the colon cancers in folks over 50. Recently, within the past several years, they've actually recommended lowering that screening age to begin at 45.
Okay.
And a statistic that I read that kind of helped back that up was that it said that folks that were born around 1990 have a 2 times higher risk for developing colon cancer in their life and a 4 times higher risk for developing rectal cancer during their lifetime compared to somebody that was born in 1950.
That is amazing. And why is that?
I think a lot of it has to do with diet, environment, the obesity crisis that has really gotten
out of hand
within the past several years.
Yeah.
And we're seeing some of the, I don't want to say benefit from that because it's not really a benefit, but some of the consequences.
Well, we have a question that we retrieved before the show and regarding the screening, and Tim has asked, how early should I screen for colorectal cancer if it runs in my family? Which is a great question.
That is a great question. There's not a straightforward, easy answer to that. It's going to depend on who in your family had colon cancer. Is this a first-degree relative, or was it my great aunt 3 times removed type thing?
Okay.
The other key is what age were they diagnosed with the colon cancer. If you have a first-degree relative that was diagnosed under age 60, that's going to be a whole lot higher risk, and then the more relatives that you start adding into that equation is going to increase the risk even more. But as a general rule of thumb, what we tell people is if there's a colorectal cancer in your family, you should start screening at age 40 or 10 years younger than the youngest person that was diagnosed, whichever comes first.
Okay. About how long does it take, for instance, when a polyp pops up, if you will, and it has been designated as a cancerous polyp? How long does it take for that polyp to actually graduate into cancer?
Well, they used to tell us that it took about 15 years or so that they thought to go from this adenomatous polyp or the precancerous type to a full-blown cancer, and that's where they came up with that whole 10-year interval on colonoscopy. Yeah. Again, just like anything else, though, everything is just kind of fluid, and there are some certain types of polyps that are a higher risk that would progress more rapidly. If you have some genetic predisposition, it may progress more rapidly, but just kind of as a general rule. Okay. That's the number that we use.
Now, you've already kind of skimmed over, and I was going to ask you so we can talk about it more in depth right now, but who is most at risk for colorectal cancer?
Everybody really has some degree of risk. We don't say no one's at zero risk. We call average risk patient, which is going to be the general population, or a higher risk. So everybody from that age 45 up needs to be in screening. The goal with screening programs is to get a greater than 80% compliance with the screening. And right now in the U.S., we're right about 2/3. So about 1/3 of people that are eligible for screening haven't been screened.
That's rather startling.
Yeah.
And, really, it's to get screened, we're talking about a colonoscopy. Is that correct?
That's one of the methods for screening. There are others as well.
The blood cult list?
Right. It's a fecal immunohistochemical test. Okay. So we just say FIT test because it's easier to say.
I'm glad you said the longer one, not me. Okay.
But FIT test once a year, colonoscopy every 10 years based off of your personal and family history, if you have polyps, you're going to have to come back sooner than 10 years, or if there's a family history, you're going to have to come back sooner than 10 years. The FIT test every year, and if that's positive, has to be followed up with a colonoscopy. There's the newer test, which is testing for different DNA mutations in the stool. Cologuard is the brand name.
Yeah.
I don't know if we can say that.
Well, there's not that many out there, so
Okay.
not too much competition for them, I don't think.
But that's every 3 years. That needs to be applied a little more, with a little more scrutiny, though, because if you do have risk factors, you really shouldn't have a Cologuard because it may not give you a true result.
Yeah, that's what I've heard. So.
Risk factors, colonoscopy is the recommendation for cancer screening.
And I have to tell you, I live in an apartment-style condo building, and we have a lot of older people in my building. It's not a senior citizen home or anything like that, but you see those boxes all the time in these cubby holes where these people get their mail. And it's like, well, at least they're trying to,
right,
be preventative, So, and that may not be the best way, the most thorough way, but at least they're trying.
Sure. Like you said, colonoscopy is the gold standard. It's what they call a one-step test for screening, in that you do the colonoscopy. If you find polyps, you can actually remove them then. Whereas if you do a FIT test or a Cologuard and it comes back positive, well, then you have to go for a colonoscopy. So,
and I think the biggest problem with the colonoscopy is the prep, as people have said. But hasn't that gotten better?
it depends on how you define better.
Okay.
Taste-wise, sure. And there are some things that you can do that are tasteless and colorless and taste like whatever you mix it in, but the effect is the same.
And the effect is just to get you cleaned out.
You have to get cleaned out in order for a colonoscopy to be effective. The colonoscopy is only going to be as good as what we're able to see at the time of the procedure.
Yeah.
If we're dealing with, trying to look through all kinds of stuff, you may miss that polyp that down the road could potentially turn to something. So it's very important to complete the prep and complete it as instructed. Within the past several years, they've actually changed to what's called a split dose prep. Whereas before you used to be 6 p.m. and then you take all your prep and that was it. Mm-hmm. Well, they found that you're going 12 plus hours with no prep, and by the time you get to your colonoscopy, a lot of that proximal, the right colon, is filled again. Oh. And so you could be missing polyps and therefore missing potential development of cancer in those areas. So now they're recommending that you do that half of your first dose the evening beforehand, and then the other half you're doing anywhere from 6 to 8 hours before your actual procedure time.
Okay.
And the idea is you still want to have that fresh prep in that proximal colon or right colon.
And I always thought when you drank it all, that was a lot.
It's a lot to drink at once, but a whole lot of people aren't real happy when you say you have to get up at 3 a.m. and drink the rest of it.
Yeah,
so,
I think I'd rather do that, to be honest with you, but different strokes.
Yeah. And it's a one-time thing. Ideally in the average risk person, if they don't have polyps, you're doing it once every 10 years. Mm-hmm. So it's not like something that you're doing frequently.
I'm sorry, but the way they put you to sleep, you're not totally under, right? Is it a conscious sedation?
It is. Most of what we do now is what's called a monitored anesthesia care. So there's actually an anesthesia provider giving what's called a propofol or Diprivan, which is a continuous infusion. So you're a little deeper than you used to be back in the 90s, early 2000s. Runs continuously, so you get a lot less of the waking up during the procedure that we used to get. We would do we would do a combination of a benzodiazepine and then a pain medicine. Doesn't give you that lingering, kind of hangover type effect. Yeah. But you still have to have someone drive you home after the procedure. You still shouldn't plan on doing any sort of serious activity or work. You can't sign any documents.
Is it okay to go ahead and eat right after the procedure?
You can. We usually tell folks, though, you want to start out on the light side. If you eat something heavy right after your scope, you're probably going to get a gut ache afterwards. And then, we get a lot of phone calls when they say, oh, I went to the Pizza Hut afterwards and ate the buffet.
That's what I did, but I did okay. Yeah. I didn't eat the buffet.
By that evening, you should be able to have back to your unrestricted diet.
Okay, very good, very good. Well, it sounds like they're coming along with that. As time goes along, it seems like it's a cinch, So there's an interesting fact that I came across too. I wanted to address tonight was why does being black increase the risk of colorectal cancer?
There's probably some predisposing genetic component, but a big part of it too is that the African American community is a lot less likely to get their screening done. So it's one of those things where getting access to the care and having the ability to get a screening test, be that a colonoscopy or the FIT test or Cologuard or what have you.
Okay, all right. That's always intrigued me. The risk factors, we talked a little bit about that, of course, the age, a little bit about the family history, but there's quite a bit more to add to that list.
Well, certainly if you have a personal history of polyps in the past, especially the adenomatous polyps, long-standing inflammatory bowel disease, be that Crohn's or even more so ulcerative colitis. There are some genetic syndromes that can run in families that are strongly associated with colon cancer development.
And I read something too that not only obesity and 3 or more alcoholic drinks a day can also be a proponent, but
smoking and
the smoking as well. Yeah, absolutely. The radiation treatment for cancer directed at the abdomen to treat previous cancers.
Right, especially if it was done during childhood. If you had a childhood, Hodgkin's or something, and you had radiation, that does increase your risk for if it was abdominal radiation, colon cancer.
If you did have that as you're a young adult, instead of waiting until you're 45, I'm sure the doctors would recommend that you would be checked.
Absolutely right. Yeah, your doctor's going to know that history and know that, that is a higher risk factor for you, and you should start your screening earlier.
Okay, that's good advice.
And a little more intense rather than the every 10 year.
All right. We have another call coming in. This is from Josie, who actually alerted us of this question before tonight's show started. And by the way, if you're just joining us, our phone system is not working tonight. It worked perfectly last night, but it's not working tonight, and we'll get that rectified for our next show. But we did have some calls, not calls, but some questions that came in off the air as well as prior to this evening. So Josie is asking, what are some symptoms of colorectal cancer I should look for? And in fact, I was getting ready to ask you about symptoms.
I tell patients, if you're waiting for symptoms, it's probably pretty
Is it too late?
It's not too late. It's never too late, but it's later in the game. Certainly, you want to pick these things up earlier and ideally at the polyp stage, so then you don't even have a cancer. But we always ask patients, have you been having abdominal pain, change in bowel habits? Are you noticing any bleeding, change in stool caliber, those sorts of things, unexplained weight loss, things in that nature.
We had a physician on who was on many, many times, Dr. Jim Edlin. I'm sure you know of him.
Yeah.
He is now a wound care doctor, since retired as a colorectal surgeon. But he always had a saying, if there's blood in your stool, it is not a good thing ever.
No, and don't just say, oh, it's just hemorrhoid, because that's what we hear all the time. Oh, it's just a hemorrhoid, so I didn't worry about it. It's only a hemorrhoid, and once you prove that it's not all these other things.
Yeah.
So, symptom-wise, it's just going to depend on what part of the colon is affected as well. If it's the proximal or that right colon, you're probably not going to have too much in the way of symptoms, but what you'll end up with is an anemia, and we don't know why. Your blood counts are low, so you end up doing this GI workup and you find, oh gosh, there's a tumor in the right colon. If it's more towards the end of the colon, that's when you're going to start getting more of the bleeding or some of those obstructive type symptoms where, hey, I'm only having, these thin stools, or, the only thing getting through is, loose stuff. And so a lot of it's just going to depend on the location.
Okay, very good. Another question we have for you, Melinda has asked us, when I hear about colon cancer, and you might have touched on this earlier in the show, but she may not have caught it. When she hears about colon cancer, it's usually in men. How often do women get colon cancer?
It's the number 3 cancer
Across
in women
the board,
as well.
number 3.
Yeah, in both men and women, number 1 is lung. In women, number 2 is breast, number 3 colon. In men, number 2 is prostate, number 3 colon.
Oh, yes.
So, and I think you had the more recent numbers on colon cancers in women from the 2024 number.
Absolutely. About 52,380 women would be diagnosed with that this year.
This year.
Yeah.
So,
all right.
significant number.
Yeah, that is a significant number, especially, and that's not deaths.
No, that's just new diagnosis.
New diagnosis.
Yeah.
So I want to break this down. I don't think I've ever asked this question before, and the number of times I've done shows on cancer in general, but can you explain what the 4 stages of cancer, and you can relate that to the colon cancer if you'd like.
With regards to colon cancer, most often we're talking about the adenocarcinoma, like you talked about, and that's what we think, begins as a polyp and then kind of progresses on from there. These are coming off of the lining of the colon, are called the mucosa. There are different layers to the bowel wall. If it's just confined to that mucosal layer, can be considered stage 1. Once it starts getting more into the muscle around the colon, that's putting more into a stage 2. And these are kind of rough estimates because each stage can be broken down, into a substage. One of the earliest places that a cancer is going to spread is going to be to surrounding lymph nodes. So when we start involving those surrounding lymph nodes, that's going to be stage 3. And then when it goes to other organs, most commonly liver, that's going to be stage 4 or metastatic at that point.
Okay. If it gets into stage 4, not to be dark, if you will, is it reversible? Are there situations?
There are definite treatment options. When we start talking about some of the later stage 2s and the stage 3s, that's when we start involving chemotherapy in addition to surgery. With stage 4, likewise, you're going to get surgery for the primary colon cancer. You're going to end up with chemotherapy, but then depending on where it is, could potentially even resect that metastatic deposit. There are, people I know that have had stage 4 colon cancer that had their colon resection, had to have part of their liver removed as well, and they're doing great.
And that brings me to another question I meant to ask you earlier when we were talking about polyps. Now, if someone has a polyp, a cancerous polyps, do you go in and take the cancerous polyp out, or do you have to do the resectioning?
If it's a cancer confined to just a polyp and it has not gone through into the muscle layer, then a lot of folks will tell you, the polypectomy alone is sufficient. This is one of those things, though, that in the hospitals, especially in bigger systems, we have what are called tumor boards, and these things are brought before the tumor board, where there's surgeons, there's oncologists, there's radiologists, there's radiation oncology, and all these different specialties talk about that particular case and then decide, is that polypectomy alone enough, or should they have other testing, should they have other surgery? If we're starting to talk about an invasive cancer or not just confined to a polyp, then that part of the colon needs to be resected. And then afterwards, depending on stage, you may need to have further treatment, be that chemo or what have you.
I see.
When we're talking about surgeries for colon cancer, it's based off of the blood supply to that particular segment of the colon, because not only do you have to resect where the tumor is, you have to get what's called a negative margin, so both upstream and downstream, as well as a round or a circumferential margin. You also need then, we talked about the different stages, you have to have lymph node along with that, so that's the lymph nodes are going to follow that blood supply. So when you resect that particular segment, you take the blood supply with it, ideally be able then to hook the colon back together.
Okay. Oh, you explained that very
well. Or
very
hook
well.
the small intestine into it if you need to.
Okay.
Rectal cancer is a little different.
Yeah, I would imagine.
And a lot of that's going to depend on, just how high up it is as to whether or not you can restore continuity to the bowel or if you have to have colostomy afterwards.
Right, okay. Well, we're getting toward the end of the show, and of course, I along with our viewers, I'm sure, are saying, okay, how can I prevent this colorectal cancer? So give us the thing on that.
Biggest thing is screening. Get screened. Like I said, there's about a third of the population that is eligible for screening that hasn't been screened yet.
And what about diet?
Diet plays a big part, and I think you alluded to it a bit as well with seeing some of these adenomatous polyps and even cancers in younger folks. Our diets aren't great.
Is that because of red meats and processed foods, or both?
A lot of red meat, a lot of processed food are going to be bad. Our diets are very fiber deficient as well, so we need to increase fiber. Watch that red meat, watch a lot of the processed stuff. You mentioned, smoking, alcohol, some of these other environmental things, modifiable risk factors, we call them, things that you can control yourself. You can't control your genetics, but you can control what you're putting in your body, how you're exercising, are you monitoring your weight? Are you doing things to try to keep yourself healthy in other ways?
How does the facet of exercise going to help keep you from getting cancer? Why is that? I mean, just across the board for all cancers, why is exercise
I think
so
a lot of it
important?
has to do with weight.
Okay.
You know, if you're carrying excess weight, it's not good for you. It's bad not just for cancers, but for orthopedic problems, joint problems, you know, back pains and things like that. Also, you know, folks that are exercising are a little bit more cognizant about what they're eating, about what they're drinking. You know, they're less likely to be smokers. I think that all kind of plays into that same effect.
All right. Dr. Jeremy Wilson, thank you so much for being with us tonight. Please come back
Appreciate it.
again.
I'd love to.
You're
Thank
becoming
you.
very, very good at this.
I appreciate it.
All right. And we thank you for watching tonight. And we hope that you'll join us again next Tuesday night at 7:30 for HealthLine on PBS Fort Wayne. I'm Mark Evans, wishing you a great night and great health as well.
The preceding program on PBS Fort Wayne was made possible in part by...
It's a new day at Parkview. Another day to rise up and make life better for those around us. Whether that means pushing the boundaries of what's been possible, taking big strides, or sitting with a patient long after a shift has ended. At Parkview, we don't just do what's expected. We do what's best for you and your family. And we're determined to do it even better tomorrow. Every person, every day. That's the kind of healthcare we believe in. Parkview Health. We believe in better.